but she tolerates me. So today I'm going to talk to you about the overview of the ultrasound pain medicine educational and training guidelines. Dr. Narouze has really been the driving force behind these, and we'll give you an overview of these today. They have been submitted to regional anesthesia and pain medicine. They are going through the review process, and they're just pending acceptance. So for some of us that work in the United States, the AMA in 1999 had Resolution 802, which says it affirms that ultrasound imaging is within the scope of practice of appropriately trained physicians. And really what they wanted to do was safely advance the progression of ultrasound in medicine, and also medical fields utilizing ultrasound, develop specialty-specific guidelines, and that's really where we came with these guidelines, is that we wanted to develop specialty-specific guidelines for chronic pain management. As you know, there's already specialty-specific guidelines for ultrasound-guided regional anesthesia. And these are to grant ultrasound privileges based on scope of practice defined in each specialty's guideline. So that's what the AMA had defined, why these guidelines should be developed. So this is obviously not unique. There has been multiple guidelines developed. If you look at rheumatology, they developed MSK guidelines in 2010. If you look at the Sports Medicine Society, they developed MSK guidelines for educating fellows in 2010. If you look at ISURA, they had the ultrasound-guided regional anesthesia guidelines in 2009. And emergency room medicine really very early on developed guidelines for education and training. 2001, and they were revised in 2008. And actually those guidelines, if anyone's interested in guideline development, those are very well written. And then also we have the TEE guidelines of 1999. So the proposed guidelines for interventional pain procedures really was just to develop a process for appropriate education and training. We developed training algorithms for fellows and also practicing pain physicians, which all of us are here today mostly. Defined required skills and scope of practice, quality improvement so we can continue to advance the field. I think it's a very exciting time for ultrasound and pain medicine, but we're still really in many ways in its infancy, and I think we're continuing to progress the field daily. And we wanted to discuss limitations, what I thought people did a very good job of today, with neurological procedures. I mean, there's really, we've seen some cervical nerve root procedures done here on the presentations, which are nice to see, but I think we have to make sure we always remember safety with real-time fluoroscopy and digital subtraction. And I think we have to slowly progress appropriately in those areas. And then the decision to grant ultrasound privileges is not based on following these guidelines, but it's really at an institutional level, and we would hope that these guidelines would serve a purpose to the institution to help decide if privileges should be granted. The foundation for this came from the ultrasound-guided regional anesthesia guidelines, which were published. You can see the title there, and that was published in 2009. There was multiple participating organizations. There was the American Society of Regional Anesthesia and Pain Medicine. I'd like to especially thank everyone in the special interest group. A lot of time was spent on this. European Society of Regional Anesthesia and Pain Therapy, Asian Australian Federation of Pain Societies, and then we had the OPEM Forum in 2011 at ISURA meeting last year, the fall pain meeting, to further discuss these guidelines and to get input. So the framework was anyone interested in learning and implementing ultrasound in the practice, both educators, practicing pain physicians, and also trainees. So there was a key task section, and I'm not going to go through all of these because of time limitations, but just to go over the highlights, we had sections on, and we had appendices too, on certain key areas that we thought were very important. One was aseptic technique, obviously the discussion of probe sterility, how that should be done. Performing a systematic scan, so you can look at normal anatomy, recognize abnormal anatomy, you should be able to visualize key landmark structures, identify the target on specific axes, short axis, long axis, and make sure that you can plan for a safe needle approach. Obviously to avoid unnecessary trauma in structures you don't want to hit. The other key tasks were following the tip of the needle under real-time visualization, and I'll talk to you about this. And it was just a nice paper that came out in 2012 talking about how there's clearly a learning curve in that. Talking about the desires of injecting a test solution, following the spread of injectate, and avoiding intratendinous corticosteroid injections and needle damage to articular cartilage, especially when we do joint injections. We also want to make sure that we have standard monitoring, that we have, when we do stellate ganglion block techniques, obviously this is a high-risk block technique, and we should make sure we're able to resuscitate patients. Make sure in some cases that we have a secondary confirmatory form of visualization. So people talked about today about the SI joint. Clearly these needles can be placed into the SI joint with ultrasound, but we also nice to have an arthrogram, also detect vascular uptake, such things as digital subtraction. And we have to really be focusing on appropriate documentation and image storage and then ergonomics. If you look at people that do ultrasound all the time, there's clearly repetitive strain injuries that can occur. So we also had a proficiency section which discussed understanding ultrasound system operations. I've seen this with some of my colleagues at my own institution. They want to just pick the probe up and start to use it right away, but there's clearly a learning curve to just understanding the equipment that we use. And I think once we understand that, we have a much better ability to perform the procedures. How to optimize your image, how to interpret your image, and make sure we have good skills with regards to needle insertion. There was 2 pathways that were defined. There was a practice pathway and a fellowship-based pathway. And all these, and it goes into much more specifics in the guidelines, but we talked about didactics, practical hands-on training, competency assessment, performance, and then in the practice-based pathway, again, that was for the current practicing pain specialist, and then the fellowship-based pathway was to structure ultrasound education during their fellowship training. We did not provide specific recommendations for a minimum number of procedures for each technique that are required to achieve the appropriate level of competency. And clearly that's going to vary based on the complexity of the procedure and also the individual's level of education and expertise. So we did not say, for example, you need to do so many sacroiliac joint injections before you're competent. That was not provided. But I think this question has been raised, and I think it clearly shows that there is a training and a learning curve to ultrasound. This was the paper published in 2012. They looked at 15 trainees, 30 simulated sciatic nerve blocks. They had a supervisor provide feedback and look at quality compromising behaviors and how to improve it. They constructed learning curves. And what they found out is how much practice do we need for a good needle visualization techniques, right? It's a technique that I think that we clearly need to understand. Trainees become competent in ultrasound needle visualization at a variable rate. This study estimates that novices would require approximately 28 supervised trials with feedback before competency in ultrasound needle visualization is achieved. So when I'm teaching the workshops today, I would say that, for example, stellate ganglion block, if you're working on your needle visualization techniques, probably not the best block to first start with. Sacroiliac joint, this was presented earlier, but we have some data showing that for sacroiliac joint, it takes quite a few blocks before we become competent. 34 patients, 60 joints, and 76% were intra-articular. For the first 30 injections, the success rate was 60%, and for the last 30 injections, it was 93%. They used a 20-gauge needle, and the mean procedure time was 9 minutes. So clearly there is a learning curve to some of these procedures. The practice pathway recommendations, we talked about CMA events. We talked about recommending 16 hours of some formal CME training. Talked about practice scanning techniques, practicing needle insertion with phantoms, and also being observed by experienced individuals. There was a push by some of the editors that we recommend a coordinator at specific institutions, and we realize this is not going to be easy, especially and I'm in private practice myself. At some private practice institutions, this will be a challenge. So it was not you needed it all the time, but if you could get someone that could coordinate this education at your institution, it would be helpful. And keeping procedure logs. For the pain medicine fellows, they want to incorporate 6 core competencies. Again, the coordinator, and there was flexibility over the fellowship to getting this training. And you could use the ultrasound-guided regional anesthesia service to assist in this training, especially when you're looking at, I think you can learn a lot on needle techniques with regards to femorals and interscalings. And we wanted to be educated on axial, peripheral, and MSK. These were some of the common ultrasound applications that were discussed. 2 of the 3 most common ultrasound applications, 2 of the 3 most common ultrasound applications that were discussed. 2 of the 3 most common ultrasound applications that were discussed. 2 of the 3 most common ultrasound applications that were discussed. 2 of the 3 most common ultrasound applications that were discussed. 2 of the 3 most common ultrasound applications that were discussed. 2 of the 3 most common ultrasound applications that were discussed. 2 of the 3 most common ultrasound applications that were discussed. 2 of the 3 most common ultrasound applications that were discussed. 2 of the 3 most common ultrasound applications that were discussed. 2 of the 3 most common ultrasound applications that were discussed. 2 of the 3 most common ultrasound applications that were discussed. 2 of the 3 most common ultrasound applications that were discussed. 2 of the 3 But we didn't go into specifics on how to do these in these guidelines, but these were some of the procedures that people had talked about. Additional recommendations, we had a section on quality improvement, image interpretation, review of your still and live images, complication rates, making sure you understand your equipment and making sure your bioengineering department checks your equipment, importance of aseptic technique and equipment cleaning, following institutional and national standards, and obviously there's going to be international differences in this. We had a section on limitations, and I think people have really done a great job presenting the limitations today on techniques. There's clearly limitations to ultrasound that we need to further advance. When you look at obesity and degenerative changes, often the spine pictures that we show you are healthy individuals. But think about the 70-year-old or the individual that has post-laminectomy pain syndrome that now has a lot of equipment in their back. Axial procedures, intravascular uptake, and that, remember, evidence-based medicine is currently lacking for areas in ultrasound pain medicine, and we're looking for suggestions and recommendations. And this is, again, opinion and clinical experience somewhat in these guidelines, and they need to be reviewed and updated at a fairly frequent basis. Thank you very much. And we had appendices, too, on aseptic techniques, documentation, coordinators, and curriculum. So thank you.